Hello everyone. This is the first module in the 7-module series for the C3-IFT course that was published by the West Virginia Office of EMS. So we're going to go through this lecture as they have it already prepared, and then we will add some additional materials in just to prep you for the test. As a course overview, there are, as it says here, there are 9 modules. However, they can be taught in different formats. The state's approved it. You must pass the written exam on the material that's covered, and it is a proctored exam, and it is given at a regional level. We really need to find out who exactly is offering that test now, other than the State Office of EMS. The time that this was created, the TSN office was the one responsible for issuing the exam. So there's 4 practical skill stations that are involved. So even though you finish and you complete this online component, you're still going to be required to come in and do the skills. So they're going to be looking at IV pumps and drug calculations. You're going to be messing with the simple ventilator and learning how to manage those types of patients. We're also going to talk about chest tubes and Foley catheter management. And then also there's a quick review again on 12-lead EKGs. So you must pass all 4 of these stations without criteria deficiencies, and it can be conducted at the squad level, and that's exactly what we're doing now. So for this course, we're going to become familiar with the key elements of what they consider the C3-IFT Paramedic course. We're going to be familiar with the main types of interfacility transports that are out there in the EMS system may be called to conduct, and then list the different classes of interfacility transport. Be able to list and discuss the various classifications of both drugs and procedures that are used within the West Virginia EMS system, and list the requirements for a paramedic to become a C3-IFT paramedic. So in interfacility patient transport, this is all types of patients from one facility to the next that's offered by EMS. This is not a new concept. This is something that we've been doing for an extended period of years. But what they have done is they've created this level of education in order to improve or maintain a good patient outcome. And we're looking at patient care being extended from the tertiary care facility and being transferred into the specialty resource centers. When we talk about a C3-IFT transport, this is a patient that is considered a stable patient. They're moving that stable patient from one facility to another, and they're receiving some form of treatment or monitoring that requires an extension of the scope of practice of the typical paramedic, and that's outlined by the classifications of transport in the Office of EMS. But when we talk about critical care transports, this is when we're talking about someone who is considered not stable, and they're needing to be moved from one facility to another for some treatment or monitoring that requires the advanced extension of the scope of practice of the field paramedic or the C3, and it requires either that specialty nurse or a specially trained paramedic at the CCT level. So these patients are not stable. That's the big difference between C3-IFT transport versus critical care. The C3 patient is a stable patient, CCT not stable. So historically in the 1970s, West Virginia Office of EMS did not have protocols. The squad medical directors kind of made the decisions on things, and we contacted the hospitals specifically for medical direction, so that it was individualized to the hospital that they were being sent to. In the 1980s to 1990s, they developed the regional protocols. This wasn't statewide protocols like we have now. They were regional protocols, and there were medical command centers that were created in order to kind of be that home point and be able to disperse the call information as needed to the individual hospitals. And then a lot of the times the hospitals did their own interfacility transport with the EMS units. So you may have the nurse from the NICU or the PICU unit that would jump on board with the paramedic, and they would continue the care of that patient. So the paramedic wasn't necessarily in charge of that patient. It was the sending facility that sent the crews out or sent their personnel out with the patient, and they were responsible. This is also the time when HealthNet became more commonly seen in the area, and then we looked at statewide EMTB protocols during this time frame. And then there was a classification that was made for drugs and procedures. In the 2000s is when we saw a statewide ALS protocol come into existence. So instead of having the regional protocols, we went to a statewide protocol, and that also meant that they had to create a divisionary point between what would be considered a stable patient and an unstable patient, and how to handle those particular types of calls, those interfacility calls. So that's when they came up with the two designations of the C3-IFT and then also the CCT level. So just a quick review on some terminology. Again, we want to remember that the transferring facility is referred to as the sending facility, and this is where the patient was actually physically seen initially, and the personnel at that facility, that sending hospital, determined that they needed to send that patient to another outlying facility for additional medical expertise or diagnostic procedures that are not available at the referring facility or that sending facility. And of course we have the receiving facility, and this is the hospital that has said, yes, we will accept that patient from your from the sending facility. So it's when a patient is transferred for additional medical or diagnostic procedures that's not available. And then we have to talk about what the standard of care is. And standard of care, as you already know, is practice the same level of care as any other competent caregiver in the community who has equivalent training. So what we are wanting to do is we're wanting to take that patient from the sending facility, and we want to maintain or improve their outcomes and their status. So when we have that C3 patient that's being sent out to higher level care, we want to maintain the patient status throughout transport. So we either want to keep the patient the same, or we want to see some types of improvement. And of course, we always have to be aware of HIPAA laws and confidentiality. So we're going to make sure that we safeguard all the confidentiality laws, except for what's required by law. Do not disclose information to third parties without written consent. And we also need to review a little bit about EMTALA, and that is very important for the sending facilities especially, and it kind of impacts us in some forms or fashions. But EMTALA is the Emergency Medical Treatment and Active Labor Act, and it is a statute that governs how patients are to be transferred and how they are expected to, how those hospitals are expected to deal with those patients. So what EMTALA does is it protects those that are coming in that may not have good insurance, and it says that the hospital is required by law to at least stabilize or attempt to stabilize that patient prior to transport. So it says yes, they can be transferred from one hospital to another if they're in an unstable medical condition, and it says that in general the hospital is going to do their absolute best to either attempt to or stabilize that patient prior to transport. When it comes to the actual classifications, we have Class 0, and this is considered the non-EMS personnel. These are specially trained personnel, such as a physician, specialty nurse, or a respiratory therapist, or a perfusionist, that are going to be jumping on board and assisting the EMS crew with that patient that's very critical. In a Class 1 transport, we're looking at having a nurse and a paramedic on board in the back of the ambulance with the EVO driver. And in the Class 2, we're talking about 2 paramedics, 2 CCT paramedics and a driver. And then a Class 3, which is what we're looking at here, the C3 or the Class 3 paramedic is running that patient, that stable patient for interfacility transfer with at least an EVO driver. And then of course the Class 4 is a regular field paramedic. When we talk about Class 5, we're seeing that being phased out. This was the EMT intermediate or the advanced care technician level. And then Class 6, of course, is our EMT basics. So to classify a transport, all drugs, procedures, or decisions should require that level of care or higher. So the proper crew configuration, inclusive of the driver, has to be present. So when what they're saying is that if you have anything from a level 2, a 0 to a level 2, then you have to have 3 personnel on board. So you have the 2 in the back plus the driver. When you hit that C3-IFT level, that's when you see that you only have to have the 2 personnel. So you have that C3 paramedic in the back and then the driver. So the functions and responsibilities of a C3 paramedic: you need to be able to maintain good ALS and C3 care. You need to know the guidelines for interfacility transport system and be familiar with the guidelines that the State Office of EMS has created. We want to maintain a professional and positive demeanor and excellent communication skills, both with the crews but also with the facilities. And we need to perform a more in-depth patient assessment than what we do normally. And as always, we want to maintain our confidentiality and have some sort of plan of care that's been formulated by the transferring facility, and we're going to maintain that through transport. So whatever orders are given to you by the sending facility, that's what you're going to maintain, that plan of care. And we're going to make sure that we do have a safe operation of the ambulance both before, during, and after all transports. So a C3 paramedic has to be a good standing paramedic in the state of West Virginia, successfully complete the C3 course, and have a recommendation placed by the squad medical director for C3 certification. And that paramedic must maintain ACLS. They must have a trauma certification such as BTLS, ITLS, or PHTLS, and then also they need to have a pediatric certification. That can either be PALS or PEP. And then as part of that C3 class, you have to obtain a score on a C3-IFT exam that's considered passing. And in order to remain a C3, you just have to continue all the in-services and updates on any drugs or procedures that either become classified or are classified as a C3 drug or procedure. And maintain all your skills and maintain and perform the skill practicals required for a paramedic. So you're really, there is no recertification exam for a C3-IFT paramedic. It's just that initial testing and then maintaining those skills and that knowledge and understanding through in-services and mandatory sessions. So with the drug classifications, you have a class 1 through class 7. Class 1 means that these are drugs that can only be either administered, re-administered, or monitored by a nurse. C2 is a CCT paramedic, and then the one we're specifically looking at here is the C3. And then you go on down through your classes as you can see here. But your drug classifications aren't just a number, they're also assigned a letter. So it may be that you have a C3A, so it says that the interfacility paramedic, that C3-IFT paramedic, can be the one that initiates or administers the medication. Or it could be that a specific drug is listed as a C3B, meaning that you can't initiate it. It has to be initiated at the sending facility before you leave, but you are able to continue or re-administer as needed throughout the transport. So that's kind of where those come into play. And then our procedure classifications, again, it's whether they're able to perform the skill or monitor the skill. So it's either going to be listed as C3C, being that maybe they did an escherotomy at the hospital and now you're just monitoring that particular procedure that was done. Or, for example, the CCT paramedic would be a class 2, so the class 2A could actually perform a chest escherotomy as needed. So that's where they're actually making a surgical incision into the skin to release pressure from burns. So who can request an interfacility transport? Well, the physician can actually request that. Staff from the sending or the receiving facility can also request it, and medical command can as well. So an IFT is dispatched as either ground or air, and of course that all goes through the medical command centers. So dispatch for interfacility transport, the sending facility or the receiving facility is going to be the one that initiates the communication, and then that information that's disseminated down to the crew should be the request assessment of the patient, what the patient is presenting as and what their chief complaint is, the history of the patient and the past medical history. So those are some things that when you get told you're getting ready to go on a C3-IFT call, you should have that information available to you at the time that you are en route to the facility. Now the paperwork that's required for transport can be anything from, and should definitely have the patient records, but can also include things like your x-rays and then any additional materials that may be on hand that's required. And then transfer forms need to be completed, such as your consents, the DNR, and so forth. Once you arrive at the sending facility, you want to make sure that you're maintaining that positive and professional demeanor throughout the entire process. You want to introduce the crew to the staff, also to the patient and the patient's family that's there, and consult the caregivers. Find out exactly what the care plan has been up to that point and what you're going to do to continue that care plan. And you're going to want to do your own personal assessment of that patient before you leave that sending facility. You want to initiate a good, solid assessment of your patient. So transport with continuous monitoring, assessment, you want to optimize and maintain patient care during transport. And that's what I was talking about earlier. Whatever their care level was, what they're receiving at this point, you want to maintain throughout the transport or make them better. And contact the receiving facility through medical command and give them an update on the patient's report, if you've had to perform any interventions, and what the estimated time of arrival is. Now once you arrive at the receiving facility, you want to make sure that you give the report, verify the information that has been given to you from the sending facility, make sure that gets to those individuals. You want to provide them with any updates on that patient and interventions that were performed, and make sure that you have all pertinent documentation handed over to them. And then you want to make sure that you complete your documentation on the approved WVOEMS form or documentation for your local agency, and make sure that you document what treatments were done prior to leaving the facility and those treatments that were done while on transport. So one of the things that commonly needs to be documented that we talk about in the interfacility world is the amount of urine that has been the input versus output. So we want to talk about what if you're leaving that sending facility, you want to drain the urinary catheter bag at that point, and you want to maybe make a mental note of how much you drained out of that bag so that the sending facility can put that documentation down. And then once you get to the receiving facility, you want to document how much urine was collected during that transport. So that is a good example of one of those things that you want to document what was done. And then sometimes you'll have treatments that were performed prior to your leaving, and that's really important, because if it's designated as a drug or a procedure classification that's outside your scope, then you want to make sure that you place the proper management or the performing of that procedure or drug with the correct individual. You don't want it to look on your documentation as though you performed something that's outside of your scope. So if there was a procedure or a drug that was administered prior to your arrival, you need to make sure that you document it as such. And then also what was done during transport. So if it's a drug that maybe you're allowed to re-administer, you want to make sure that you list that appropriately. And again, that kind of comes back into what we're talking about. You're looking at the medications that were taken prior to your arrival at the sending facility, what their intake and outtake was, and then medications that were given en route. So the C3-IFT paramedic will be obtaining the medications for transfer from the from the sending facility, and be sure that the sending physician has provided you with all the written orders that you need for that drug or procedure that they may require during transport. So make sure you have all your written orders with you. And this concludes the section on Module 1 for Overview and Introduction to C3-IFT Transports. If you have any questions, please feel free to reach out to me at any time. Thanks.